Today we are going to study about oxygen therapy, oxygen sources, oxygen delivery by the mask and cannula, oxygen monitoring, and minimizing wastage. What is oxygen therapy? Oxygen therapy is the administration of oxygen at a concentration or pressure greater than that found in the environment. Goal of supplemental oxygen therapy is to ensure appropriate oxygen delivery to vital end organs tissue. Oxygen therapy is a key treatment in respiratory care. Oxygen should be written legibly by the doctor. Prescription should be dated by the doctor. Doctor must indicate duration of oxygen therapy. The O2 concentration must be prescribed. The flow rate must be prescribed. Now, what do you mean by tissue hypoxia? The tissue hypoxia is defined as governed by the balance between oxygen delivery and oxygen utilization. Generally, failures in oxygen delivery leads to most instances of tissue hypoxia. Now, O2, the oxygen delivery is equivalent to cardiac output, is into by CaO2, that is oxygen content of arterial blood. Oxygen content of arterial blood is calculated by the formula that is CaO2 equal to 1.34 into hemoglobin concentration into SaO2 plus 0.0031 into PaO2. From this formula, the causes of poor oxygen delivery can be narrowed by three categories. First category is the IAP, low cardiac output state. For example, various forms of shock, low hemoglobin concentration state, for example, anemia, and low SaO2 state, example, arterial hypoxemia. Now, what are the indications of oxygen therapy? First indication is in the acute circumstances. Accepted indications, documented hypoxemia, defined as CaO2 below the normal range. Usually, CaO2 is more than 60 mmHg or SaO2 more than 90%. Acute care situations in which hypoxemia is suspected, such as respiratory distress, required substantial of hypoxemia is by SaO2 or PO2 in a reasonable time. Then the second cause is severe trauma, acute myocardial infarction, and hypoxemia. The low cardiac output with metabolic acidosis, pneumothorax, hypotension in the systolic blood pressure more than 100 mmHg. Now, questionable indication. Acute myocardial infarction with hypoxemia, dyspnea with hypoxemia, sickle cell pain crisis. Now, oxygen delivery device. Now, there are two kinds of oxygen delivery devices. One is low flow, second one is high flow. In low flow, variable performance are there. First is nasal cannula, second is oxygen mask, third is mask with reservoir bag. In the high flow, we get a fixed performances, that is ventricular mask, high flow nasal cannula, high flow oxygen generator. Now, what is low flow? The low flow systems deliver only a fraction of the patient's minute ventilation as pure oxygen. The minimum flow in these systems is 15 liters per minute. Since the patient tidal volume usually varies from breath to breath and the delivered flow of oxygen from the device is constant, the fraction of inspired oxygen for any given breath is impossible to predict. Because of uncertainty of the FiO2 delivered by low flow devices, they are sometimes referred to as variable performance devices. Now, the first kind of low volume, low pressure cannula is nasal cannula, which is called as prong. It is a disposable plastic device with two protruding prongs for insertion into the nostrils connected to the oxygen sources. Second, it is used for the low medium concentration of oxygen, 24 to 44% at a flow. The rate of nasal cannula is 1 liter to 5 liter per minute. Flow above 5 liter per minute do not increase FiO2 above 44%. Now, this is the structure of nasal cannula, which is also called as crown. Now, what are the advantages and disadvantages of nasal crown? First, the advantages are client able to talk and eat with oxygen in place. Second, easily used in home settings. Third, safe and simple. Fourth, easily tolerated. Now, what are the disadvantages of nasal cannula? First, delivers low concentration of oxygen, unable to use with the nasal obstruction, can dislodge from nares easily, causes excessive mucosal dryness and epistaxis at 6 liters per minute or higher. The simple oxygen mask. Now, this is a simple oxygen mask. As in this simple oxygen mask, the first thing which you can see, that is a metal piece conforms to shape of a nose. Second, the holes which is presented over there, that is the exhalation port. The third, from which we are going to get the oxygen supply, that is the oxygen source, this narrow pipe. And third, that is the strap. Now, the oxygen mask, it delivers 40% to 60% of oxygen. The flow rate for simple mask ranges from 5 to 12 liters per minute, which usually requires some room air to be entered via the side ports of the mask to meet the patient's minute ventilatory needs. The flow rate of a simple mask should never be more than 5 liters per minute. Below this level, the carbon dioxide rebreathing may occur along with an increased resistance to the inspiration. Now, its advantages and disadvantages. The first advantages can provide increased delivery of oxygen for a short period of time. This is the basic advantage of oxygen mask. The second advantage is the face mask is indicated in the patient with nasal irritation or epistaxis. The disadvantages of nasal mask is, face mask is, the tight seal required to deliver high concentration oxygen, difficult to keep mask in position over nose and mouth, uncomfortable for patient while eating or talking, and claustrophobia. Mask with reservoir bag. Two types, that is one, partial rebreathing reservoir mask. Second, non-rebreathing reservoir mask, provided flow breathing between 8 to 15 liters per minute. The partial rebreathing reservoir mask. This is one of the kind of reservoir mask. Now, in this mask has a reservoir bag that must remain inflated during both inspiration and expiration process. It collects the first part of the patient's exhaled air. The oxygen flow rate must be maintained at a minimum of 6 liters per minute to ensure that the patient does not rebreathe large amount of exhaled air. The remaining exhaled air exists through the vents. It is used to deliver oxygen concentration up to 80%. Now, its advantages and disadvantages. The advantage of it is can inhale room air through opening in the mask if oxygen supply is briefly interrupted. Now, disadvantages are required tight seal, eating and talking difficult, uncomfortable, and claustrophobia. Now, rebreathing mask, which is also called as NRBM. The non-rebreathing reservoir mask. It is called as a kind of non-rebreathing reservoir mask. It is a second type of mask. It's defined as the highest, which provides the highest concentration of oxygen, that is 60 to 100% of oxygen at a flow rate of 4 to 10 liters per minute. It is similar to the partial rebreathing mask, except that two one-way valves are present to conserve the exhaled air. The bag is an oxygen reservoir. When the patient exhales, the one-way valve closes and all the exhaled air is vent out, and the patient not rebreathe any of the exhaled air. Now, its advantages and disadvantages again. Its advantages delivers the highest possible oxygen concentration, suitable for the patient breathing spontaneously with severe hypoxemia. Now, its disadvantages, impractical for LTOT, malfunctions can cause CO2 buildup, suffocation, extensive, and again, claustrophobia. Difference between simple partial rebreathing, NRBM, O2 mask. Now, simple O2 mask, partial rebreathing reservoir mask, and non-rebreathing reservoir O2 mask. Now, these are the three kinds of masks which is being available for the patient. Now, in the simple O2 mask, it's said to be provide FiO2 40 to 60% at a flow rate of 6 to 10 liter per minute. Flow rate must be 5 liter per minute to prevent CO2 rebreathing. No one-way valve presented for inspired and expired gases. In the partial rebreathing reservoir O2 mask, it provides FiO2 60 to 80% at a flow rate of 6 to 10 liter per minute. Flow rate must be 6 liter per minute. It ensures that patient does not rebreathe exhaled air, and no one-way valve presented for inspired and expired gases. Now, rebreathing reservoir O2 mask. It provides FiO2 60 to 100%. Flow rate should be 4 to 10 liter per minute. Flow rate should be set high to prevent deflation of reservoir bag, usually about 15 liter per minute. One-way valve presented for inspired and expired gases. Now, the estimation of FiO2 in a nasal cannula, O2 mask, and mask with reservoir. Now, as you can see in the chart, what are the estimated FiO2 which is needed in the different kind of oxygen supply? When you put a patient in a nasal cannula, when you put a patient on O2 mask, that is a simple O2 mask. And when you put a patient on a mask with reservoir. So these are the estimated FiO2 rates, which differs according to the patient condition, how they actually needed oxygen, in what condition and in what manner. Now, the high flow or fixed performance oxygen devices. The high flow oxygen devices deliver a constant FiO2, therefore referred as fixed performance devices. The device allows for a fixed FiO2 by providing very high flow of pure oxygen, which exceeds the patient minutes ventilation, sometimes by a factor of 4. Now, Venturi mask. What do you mean by Venturi mask? A Venturi mask consists of a mask, a jet nozzle, and the entrapment port. Oxygen is delivered under pressure by the jet nozzle, which acts to dramatically increase the velocity of the gas, provide high concentration of oxygen from 24 to 50% at 3 to 15 liter per minute. Venturi mask has inchargeable or adjustable valve that enables the clinical or respiratory therapist to better triage that FiO2 of the patient actually be needs. Now, this is a Venturi mask, which is given to the patient, which actually provide a high kind of oxygen when a patient actually needs. Now, the advantages and disadvantages of Venturi mask. The advantages are delivers more precise oxygen concentration, does not gives a dry mucous membrane. These are the two advantages of Venturi mask. Now, the disadvantage is uncomfortable, risk for skin irritation, then produce respiratory depression, basically in conditions the patient who are suffering with COPD, patient with a high oxygen concentration, who are having a 50% oxygen concentration. Now, the high flow generators for O2 therapy. The high flow generators, they are used to ensure non-invasive delivery of a constant high concentration of inspired oxygen. The high flow generators are capable of delivering gases in excess of 40 to 60 liters per minute. Now, the high flow generators for supplying the oxygen therapy, they basically deliver 40 to 60 liters per minute. It's given the high flow delivery a constant FiO2. This is the process, the high flow generator, they actually achieve the highest FiO2 in regards of the patient minutes. Ventilations are fit to the mask. The devices are noisy and require specialized persons to set up and monitor, limiting their usage to intensive care settings. High flow nasal cannula. Recently, nasal cannula that can deliver much higher rate of flow than simple nasal cannula have been developed. For example, Vapotherm that allow deliver of high much flow and therefore high FiO2 of humidified oxygen. The device can deliver between 1 to 60 liters per minute and may be more comfortable than a face mask. This is the high flow nasal cannula, as you can see. Now, what are the hazards of O2 therapy? First hazard is, which you can call it as disadvantage of O2 therapy. Then the first disadvantage is drying of mucous membrane. Second, the depression of ventilation and COPD, atelectasis due to absorption collapses, O2 toxicity, ARDS, and bronchopulmonary dysplasia. Now, retrolental fibromyalgia. It occurs when CO2 is more than 80 mmHg for more than 3 hours in newborn. Very premature babies are more susceptible. O2 saturation must be around 90 to 92% to prevent it. Thank you. This is the basic course which we actually know about. What do you mean by oxygen therapy and which are the manners by which we can give oxygen supply to the patient in the intensive care unit or the patient who are lacking of taking the proper respiration and inspiration. Thank you. Now the second topic we're going to study today is the uses of NIV and high flow nasal oxygen. Now the introduction, the non-invasive ventilation, which is called as NIV. It is referred to the delivery of positive pressure ventilation through a non-invasive interface rather than an invasive interface. Non-invasive interface nasal mask or face mask or nasal plug. Non-invasive ventilator can be used as ventilatory support for the patients with acute or chronic respiratory failure. So this is the device which is called as non-invasive ventilator, which is basically given the ventilator support to the patient, which are basically suffering with the chronic respiratory failure or in the acute phase of respiratory failure. As you know, the types of acute respiratory failure, there are 3 kinds of respiratory failure. So this is the non-invasive mask, non-invasive ventilation mechanism and the machine, which is basically provide the ventilation, proper oxygen therapy for the patient. Now, what are the physiological effects of non-invasive ventilation? As in the traditional positive pressure and ventilation, non-invasive ventilation has 2 primary pressure settings. One pressure setting is used during the inspiratory phase and the other during the expiratory phase. During the inspiratory phase, now the invasive, non-invasive ventilator is consisted of 2 phases. First, the inspiratory phase, and second is the expiratory phase. Now, what happens in the inspiratory phase? In the inspiratory phase, the inspiratory positive air pressure, that is called as IPAP, works like another positive pressure breathing, that is ventilation device. The IPAP level is similar to the peak airway pressure in the traditional mechanical ventilation. A higher IPAP level would result in a large tidal volume and minute ventilation. The expiratory, the second mechanism is the respiratory positive airway pressure, that is EPAP. And the same as the PEEP during mechanical ventilation or CPAP during spontaneous breathing. In addition to its ability to improve oxygenation by increasing the functional residual capacity, EPAP also relieves upper airways obstruction with its splitting action. Since 2 benefits of NIV are improvement of PO2 and PCO2, these 2 parameters can be used as titration endpoints. If ABC results are available, oxygenation, CO2, and the ventilation PaCO2 endpoints can be easily accessed. Alternatively, pulse oximeter, that is SpO2, and capnography, that is PET-CO2, may be used for the titration of appropriate IPAP and EPAP, that is inspiratory and the expiratory level in the non-invasive ventilation mechanism. Okay. Now, this is the chart, which is the type of non-invasive positive pressure ventilation. The continuous positive airway pressure, that is called CPAP. Now, its application is obstructive sleep apnea, then congestive heart failure with coexisting obstructive sleep apnea. These are the different where CPAP is same. And obesity, hyperventilation syndrome, then coexisting obstructive sleep apnea, then setup required that CPAP level when the patient these are the conditions where the patient is needed to put on the non-invasive positive pressure ventilation. Now, the advantage of non-invasive ventilation in this conditions are simple tools, relatively inexpensive. But the disadvantage of non-invasive ventilation in the conditions of heart failure, obstructive sleep apnea, the disadvantages are minimal or no ventilation port. Present pressure may not address variability on obstructive apnea, the severity sleep stages, and further stages. Now, the second kind of non-invasive positive pressure ventilation, that is autotap. The application, this is used in the condition like obstructive sleep apnea, congestive heart failure with existing obstructive sleep apnea. These are the conditions. Now, the sub requirement range of allowable CPAP. Its advantages are huge number of titration studies like suggestions to add to variability and obstructive sleep apnea with sleep states with and for the small changes may be useful for the patient with ongoing weight loss, such as after bariatric surgery. Disadvantage. Now, the disadvantage is advantage, reduced number of titration studies, self-adjusting to adapt to variability in obstruction sleep apnea, with sleep stages. Positional changes may be useful for patients with ongoing weight loss, such as after bariatric surgery. Then the disadvantages of it is the more expensive than fixed CPAP. Then more expensive than fixed CPAP may not be effective for the patient with cardiopulmonary disorder, other conditions in which destruction may be unrelated to obstructive events. Now, the third kind of non-invasive ventilation is adaptive servo ventilation, ASV. The application, it is also used as congestive heart failure, central sleep apnea, complex sleep apnea syndrome. The setup requirement, that is minimum and maximum inspiratory pressure and end expiratory pressure. Its advantages, adapt pressure to maintain more consistency of respiration over time. Its disadvantages, more expensive than the other modes, may worsen ventilation in diseases with chronic ventilator insufficiency, such as COPD and obstructive thoracic disorder. Now, the other is bi-level positive airway pressure, that is called as BiPAP, without backup rate. Its application, this is also used in the same obstructive sleep apnea with CPAP intolerance, obstructive sleep apnea with central sleep apnea, restriction thoracic disorder, severe chronic obstruction, pulmonary diseases, obesity, hypoventilation syndrome, and coexisting obstructive sleep apnea, residual hypoventilation despite CPAP. Now, these are the conditions in which BiPAP is needed. The setup, that is inspiratory, expiratory positive airway pressure. Advantages, promote alveolar ventilation, uploads respiratory muscles, decreases the work of breathing, control obstructive hypopnea. Disadvantage, more expensive than CPAP, may generate central apnea with backup rate. Application, central sleep apnea, complex sleep apnea syndrome, worsening restrictive disorder. Now, the setup requires inspiratory, expiratory, positive air pressure. Now, all these are having the same process, which is the same setup requirement, that is inspiratory and expiratory positive airway pressure. The backup ratio of inspiratory time to the expiratory time. Now, its advantages is provide mandatory respiratory support during central and pseudo-central apnea. Disadvantage, more expensive than conventional BiPAP, mid-century central apnea. Now, the third is average volume assured pressure support, that is AVAP. Application, the same kind of application is there. Obesity, hypoventilation syndrome, neuromuscular disease, chronic obstructive pulmonary disease. The setup, target tidal volume 8 milliliter per kg of idle weight, inspiratory positive air pressure limit, respiratory rate, advantage ensure a delivery tidal volume, compensate for the decrease for the disease progress. Disadvantage, more expensive than the other mode. Now, what are the indications? We have seen the non-invasive ventilators. They are consistent of two types, two mechanisms, that is inspiration and expiration. Then there are two types of non-invasive ventilation. That is the first one is like CPAP and the second one is BiPAP. Now, we have also seen the type of CPAP and we have also seen the type of BiPAP. Now it comes to the indication of non-invasive ventilation. So the first indication is acute exacerbation of chronic obstructive pulmonary disease, that is AECOPD with hypercapnic respiratory acidosis. Now it is called as in a condition for patients with AECOPD complicated with hypercapnic, for example, respiratory acidosis. PaCO2 is more than 45 mmHg, 6 kPa or PA more than 7.35. Initially, trials are bilevel NIV. Bilevel NIV is the mode of choice. Now, the second indication is acute cardiogenic pulmonary edema, that is ACPE. The mechanism by which NIV improves ACPE is through be due to preload reduction, the prevention of alveolar collapse at the end expiration, and decrease of left ventricular afterlife. For patients with ACPE, we recommend a trial of NIV typical with CPAP. Meta-analysis of a small randomized trial in the patient with ACPE report that NIV decreases the need of intubation, improves the clinical and laboratory indices of respiratory failure, and improves mortality. Most patients with ARDS require invasive macro ventilation. However, we reserve bilevel NIV for the occasional patient with mild ARDS who is hypodynamically stable, easily oxygenated, and has no contraindication to its use. Fourth, that is pneumonia. Benefits from NIV in patients with pneumonia is variable. Some data suggests that bilevel NIV is beneficial in patients with acute hypoxemic respiratory failure due to pneumonia, provided they are able to manage their secretion. In one trial that demonstrated benefit from NIV in the patient with acute hypoxemic respiratory failure of varying etiology, the mortality benefit and reduced intubation rate associated with NIV use were most evident in the subgroup of the patients with pneumonia. Now, these are the indications where NIV is given, where NIV is needed. Now, the sixth is immunocompromised patients. In the immunocompromised patient, it's needed for the treatment of acute hypoxemic respiratory failure. Then post-extubation respiratory failure, NIV has been used in the patient who developed acute respiratory failure in the first 24 to 72 hours following extubation. Then the seventh, the post-operative respiratory failure. NIV has also been used to treat patients who develop acute respiratory failure in the post-operative setting. Now, the eighth is the chest trauma, induced respiratory failure. Then, the indication for non-invasive ventilation. The first indication, that is chronic obstructive pulmonary disease. NIV without backup rate. In this, these are the conditions which we can see. So the first one is in the non-invasive ventilation indication. First indication we can see is chronic obstructive pulmonary disease. These are the conditions where you need the PaCO2 is more than equal, less than equal to 50 mmHg. The O2 saturation is more than equivalent to 88%. The higher of the oxygen supply would be 2 liters per minute of the oxygen level. Then the CPAP treatment has been considered and ruled out by the facility based on the nocturnal polysomnography. Now, the second indication which is needed in the non-invasive ventilation is the destructive thoracic disorder, that is progressive neuromuscular diseases or thoracic cage abnormal, in which you can need NIV with or without backup state. In this, PaCO2 would be more than equivalent to 45 mmHg, or O2 saturation is more than equivalent to 88% of a person minute. In this, you have a proper rating of everything, in which how much PaCO2 is needed, how much oxygen saturation is needed, how much maximum inspiratory pressure is needed. You need to remember all the things when you need a patient to be put on the non-invasive ventilator. But these are the conditions. When you put a patient in a non-invasive state, when you put a patient on non-obstructive pulmonary disease in a non-invasive process, then these are the rating and the conditions. When you put a patient in the destructive thoracic disorder with progressive neuromuscular disease or the thoracic cage abnormality, then these are the readings which you need to remember. Then the third indication, that is central sleep apnea or complex sleep apnea syndrome, which includes non-invasive ventilation with or without backup rate. Now, these are the ratings which you really need to remember. Then the fourth condition, indication of NIV, that is obstructive sleep apnea, okay, which includes CPAP, that is continuous positive airway pressure. Now, in this also, you need to remember all these readings, that is apnea, hypopnea, syndrome index, respiratory disturbance index, how much minimal events should be there, how much inspiratory and expiratory pressure should be there, what are the symptoms presented over there, in which there would be a cardiovascular risk presented, like excessive daytime sleepiness, impaired congestion, mood disorder, insomnia, hypertension, ischemic heart disease, history of stroke. So NIV without backup rate. About the criteria, CPAP is ineffective or polysomnography or at the home cardiorespiratory monitor. Then the other indication, that is hypoventilation syndrome, which will also include NIV without backup rate. In this also, you need to remember all these indications. These are the conditions which you need to keep in the mind when you don't need NIV backup rate. Now, what are the procedures to try positive airway pressure? First, the setup mode, spontaneous and time. Second, start the IPAP, that is, start the inspiratory pressure rate, okay, at 8 centimeter H2O, and the expiratory rate pressure at 4 centimeter H2O. Then set IPAP minimum time of 0.15 to 0.25 seconds, longer than the patient's acute inspiratory time. Then IPAP minimum time should not be set longer than 50% of the expiratory cycle. Then attach mask to patient, ensure proper fit, and start the machine. Then the 6-point increases IPAP is 1 to 2 centimeter H2O increments to provide monitor ventilator assistance and large tidal volume. 7th, it increases APAP in 1 to 2 centimeter H2O increments to improve oxygenation or to relieve upper airway obstruction. If poor synchronization occurs, then check for the leak or altered IPAP maximum time to improve synchronization. Use supplemental oxygen if baseline saturation remains low with appropriate IPAP and EPAP settings. Do not increase IPA3 and EPA3 levels beyond patient tolerance. Now, these are the potential indications for success in non-invasive ventilators. So, if you need a successful non-invasive ventilation process to get succeed, you need to remember all these indicators and need to keep these indicators in your mind before using the non-invasive ventilator process. First, the young age, then second, the low acuity of illness. Second, third, if they are able to cooperate, better neurological scores. Fourth, less early get intact dentition, moderate hypercarbia, moderate acidemia, improvement in gas exchange, and heart respiratory rate within first 2 hours. So these are the indicators if you need to put the patient on non-invasive ventilator process. If you don't keep this in mind, then you won't be able to put a patient in a non-invasive ventilation and in a proper successful manner. Now, what are the management of complications and side effects of non-invasive ventilation? First, we'll go through the complications and with its complication side effects with its action. The first complication and side effect complication or the side effect is air leakage. So its action is prevention of neck flexion, semi-recumbent positioning, use of chin rest, use of cervical collar, switch to control pressure mode, decreases peak inspiratory pressure or increases volume optimize the interface using the oronasal mask. Second, the nasal dryness congestion. Third, that is the action is cold pass over. Third complication is aerophagia, eructation, fluctuant abdominal discomfort. Its action is heated humidifier, decreased peak inspiratory pressure below 25 centimeter H2. Now, as you can see, its advantage, the comfort, patient compliances, and the disadvantage, that is a gas leakage, nasal dryness, or drainage. You can see over there how you need to put the patient mask in a proper manner, how you need to put an IV mask on the patient in a proper situation. Now, what are the advantages? The first advantage is good seal. Second, more effective ventilation. Yes, I know one thing, it's like it becomes very much uncomfortable for the patient when you put that NIV mask on the patient's face. First, for most common side effect is the patient becomes claustrophobic because it gets covered up from all the sides. So the first disadvantage is claustrophobic. But still, if you want to give the patient high flow need oxygen supply, then you have to put the patient in NIV mode. So first, the advantage is it's a good seal. Second, it's more effective ventilation. The disadvantage, that is claustrophobia, patient non-compliances, regurgitation, aspiration, excitation and power or gas outage, alarm and monitor are necessary. Now, this is the mode of supply, how you can fix the NIV mask. What are the masks? These are the belts, these are the gauge, these are the mask, complete mechanism, how you have to put. These are the wing knobs, these are the nasal pillow, these are the plump shells, and these are the different parts of the NIV mask. So you need to keep this thing in mind if you need to put a patient on NIV mask. Now, this is how you give a patient a kind of breathing that is called as this is the process which is used in CPAP therapy. This is most commonly used in CPAP therapy. That is a nasal pillow device, more comfortable than neuronasal mask. But gas leak is a potential problem, especially in men with the beard and mustache. It signifies gas leak occurs through the mouth. A chin strap may be used to close the mouth, or an oronasal mask should be considered. More commonly used during CPAP therapy. So you need to keep everything in mind. The full face mask is ideal for claustrophobic patients, mouth breathing, patient without teeth, or with facial abnormalities. As you have this time seen, this is the kind of NIV mask most commonly in the present scenario we have seen from last 2 years. The patient who have been actually suffering from corona, we have seen when the patient is not having the proper inspiratory and expiratory rate, and when they are having a slow saturation volume. So we have mostly put in the patient of NIV mode, an NIV system mode, so that a patient can have a proper successful rate of oxygen supply in their body. So that is much more successful for the patient. Might be you have remembered in the second cycle of COVID, you have seen many of the people who are having a downfall of saturation. Within the 7 period of downfall, we were actually putting the patient, more and more patient on NIV mode, which was really helpful. Now the choice of mask. Now the choice of mask goes into the consideration the type of treatment planned and favoring the mask which delivers the positive pressure to both the nose and the mouth. If the patient is a mouth breather, is of great importance. Every effort should be made to minimize air leakage and maximize patient comfort and optimize patient ventilator interaction. Heating and humidification may be needed to prevent adverse effects from cool, dry gas. Now, these are the contraindications for non-invasive ventilation. So, contraindication in which contraindication means in the process where you cannot use non-invasive ventilation. First indication, absolute, the need for the immense intubation, for example, that is cardiac respiratory arrest, severe respiratory distress, unable cardiac arrhythmia. That is a absolute contraindication. Now, the relative contraindication for non-invasive ventilation. First is non-respiratory organ failure, that is actually life-threatening. Then severe encephalopathy. Then severe upper gastrointestinal bleeding. Then hypodynamic instability. Then facial or neurogenital surgery, trauma, or deformity. Then significant airway obstruction like laryngeal mass or tracheal tumor. Then inability to cooperate, protect airways, or clear secretion. For example, patient at a high risk or aspiration. Anticipated prolonged duration of mechanical respiration. Then recent esophageal, gastric, anastomosis, multiple contraindication, insufficient staffing support. So that are the contraindication where you need to think where you have to use non-invasive support or not. Now, high flow nasal oxygen. Now, what is high flow nasal oxygen? This is the kind of instrument by which high flow nasal oxygen is being supplied through the nasal prong. As here is a humidified oxygen, this is the flow rate, here is the FI2, and the oxygen, humidified oxygen is supplied through the nasal prong. Okay. First, the introduction. In the introduction, high flow HFNO, that is called a high flow nasal oxygen. It is defined as it's a piece of equipment that delivers steady, warm, and humidified oxygen at very high flow rate, nearly 60 liters per minute, through a plug that are fitted to a patient's nostrils. High flow nasal oxygen cannula is lighter. Patient on HFNO can talk, eat, and drink. Now, what are the benefits and mechanism of oxygen delivery by HFNO? That is the mechanism and clinical benefits. First mechanism is small, peeable nasal prong. Its clinical benefit is enhanced patient comfort. Second, heat and humidification. So its clinical benefits are facilitates removal of air secretion, avoids air dissection and epithelial injury. It decreases work of breathing, enhances patient comfort. Now the third mechanism is washout of nasopharyngeal dead space. The clinical benefits is improve ventilation and oxygen therapy. So in comparison to the non-invasive ventilation, which we have studied, it's also a kind of oxygen supply method. So in comparison to that, this is also a high flow nasal oxygen supply. So this is much more easygoing in comparison to non-invasive ventilation process. So first mechanism was small, peeable nasal prong. Second is heat and humidification. Third is washout of nasopharyngeal dead spaces. Now, fourth is positive end expiratory, that is PEEP effect. Now, its clinical benefit is upload auto PEP if present, then decreases work of breathing, then enhances oxygenation, then high nasal flow rate. It is reliable deliverer of fraction of inspired oxygen, then improvement breathing pattern. For example, increase tidal volume, decrease respiratory rate. Now, HF, high flow oxygen. In this, the indications are in patients with severe hypoxemic respiratory failure. For example, partial arterial pressure of oxygen, fraction of inspired oxygen. The high flow nasal cannula is an alternative. High flow nasal cannula is often better tolerated than oxygen mask due to enhanced patient comfort, reliable delivery of FiO2, and the potential reduction in the work of breathing. So in a comparison, if we go through a comparison, we can show in comparison to the oxygen mask, high flow nasal cannula is much more comfortable. Why? First, because it gives a patient comfort. Second, it gives the reliable delivery of FiO2. Third, it decreases the potential reduction in the work of breathing. Then the third indication, the main use of high flow nasal cannula is to provide a relatively high flow FiO2. You need to keep this in mind that high flow nasal cannula, it provides the highest FiO2 to the patient. The patient with severe non-hypercapnic hypoxemic respiratory failure from medical causes. As an alternative to NIV. In the alternative where NIV cannot be used, so there are the conditions. The high flow nasal cannula may be used in alternative to NIV or for the provision of adequate oxygenation during break from NIV. High flow nasal cannula is unlikely to provide sufficient PEP for those who need it. Example, moderate to severe ARDS. ARDS is a kind of respiratory condition and cannot be used for those who require NIV for ventilation. Hypercapnic, hypoxemic respiratory failure due to hypoventilation. It is also unlikely to reduce the work of breathing as effectively as NIV. So these are the alternative conditions where you don't want to use NIV method, but you can go for high flow nasal cannula. Now, the high flow nasal cannula versus low flow oxygen. These are the conditions. First, the patient with hypoxemic respiratory failure that constantly demonstrate improved oxygenation and decreased need for intubation when compared with low flow oxygen system. However, studies have failed to show consistent and convincing benefit on mortality, intensive care unit, and hospital length of stay, dyspnea, and comfort. Pro-extubation support, high flow nasal cannula has been employed as adjacent support measure in the patient following extubation. So when you need to extube, when a patient is on a ventilator, but when you have a good improvement on a patient, so from removing from the ventilator, before extubation, you put slowly, you reduce all the rate and you try to put slowly patient on the high flow nasal cannula. So it's really you need to keep that in mind that high flow nasal cannula, it provides a good FiO2 to the patient. Third, that is post-operative respiratory failure. So in this also, high flow nasal cannula has also been used successfully in the treatment and prevention of the post-operative respiratory failure. Also not routine, high flow nasal cannula is an acceptable way to provide oxygen to the patients undergoing intubation, both before pre-oxygenation during the process to prevent the desaturation. Then other conditions, patients who are weaning via tracheostomy may potentially benefit from high flow nasal cannula. The patient who is weaning through tracheostomy, the patient who already has tracheostomy done. In this patients also high flow nasal cannula is very much beneficial for them. And high flow nasal cannula has also been used to successfully oxygenated hypoxemic patients undergoing fiber optimic bronchoscopy. So the patient in which you need to go for the bronchoscopy, that is fiber optimic. In this also you can go into high nasal flow cannula. Now, what are the complications of high flow nasal cannula? First, include abdominal distension, aspiration, rarely barotrauma, that is called as pneumothorax. Then risk of barotrauma is likely lower with nasal high flow cannula than with NIV or mechanical ventilation following endotracheal intubation. So these are the complications which you really have to keep in the mind, and you need to keep on checking the other organs too if you're putting a patient on high flow nasal cannula. The contraindication of high flow nasal cannula, it includes the abnormalities or surgery of the faces, noses or airways that precludes an appropriate fitting of nasal cannula. Some experts avoid high flow nasal cannula in those following upper airway surgeries to avoid the risk that the high pressure may participate a venous thromboembolism. Now, the clinical application of mechanical. So these are the studies where you can see what is about the non-invasive ventilation, what is exactly about the invasive ventilation, what is about high flow cannula, high flow nasal cannula. So this is all about it. First, we have studied about what is about how you can provide the patient oxygen in a proper level, how much amount the patient needed, the oxygen level. The third topic which we're going to study today is acute respiratory failure. What do you mean by acute respiratory failure? Now, the acute respiratory failure, it is defined as a condition in which the respiratory system fails in both one or both of its gas exchange and function, that is oxygenation of carbon dioxide, elimination from mix of venous pulmonary arterial blood. Hence, respiratory failure is a syndrome rather than a disease. Acute respiratory failure is characterized by life-threatening derangement in arterial blood pressure and acid-base states. Now, the respiratory failure may be classified as hypercapnic and the hypercapnic respiratory failure. It is defined as an arterial PCO2 greater than 45 mmHg. Hypoxemic respiratory failure, it is defined as arterial PO2, that is PaO2, less than 55 mmHg. When the fraction of oxygen is inspired airflow, FiO2 is 0.60 or greater. In the acute respiratory failure, there are two conditions, that is hypercapnic and hypoxemic. As you can see, what is this acute respiratory failure? Then the acute respiratory failure, that is basically divided into two main kinds, that is hypercapnic and hypoxemic. Now you have seen the kind of reading which is actually needed, which is actually given. What do you mean by hypercapnic, hypercapnic respiratory failure, and what is hypoxemic respiratory failure? Now both develop within the minute to hours. Now, what is physiotherapy? Pathophysiology for acute respiratory failure. The respiratory failure can arise from an abnormality in any kind of condition that is effective component of the respiratory system. Central nervous system, peripheral nervous system, respiratory muscles, and the chest wall, airways, or alveoli. A defection in any of the first four components. The first four components, that is the central nervous system, peripheral nervous system, respiratory muscles, chest walls, airways, and alveoli, which constitutes the respiratory pump, may cause coexistent hypercapnia, hypoxemia, at least initial disorders of the alveoli, or more appear to result in hypoxemia. So what do you mean by respiratory pump? The central and peripheral nervous system, these are the content, okay? The central and peripheral nervous system, respiratory muscles and chest wall, and the airways. Hypercapnia is a hallmark of respiratory pump failure, while hypoxemia constitutes the primary disturbances in alveoli disorder producing respiratory failure. Hypoxemic respiratory failure, four pathophysiological mechanisms account for the hypoxemia seen in a wide variety of diseases. Now, there are four wide variety of diseases. in which the hypoxemic respiratory failure is seen. They are alveoli hypoventilation, ventilation that is perfusion mismatch, shunt, and a diffuse limitation. Then hypercapnic respiratory failure at a constant rate of CO2 production, PA, CO2 is determined by the level of alveolar ventilation. The relationship between alveolar ventilation, rate of CO2 production, and PA CO2 is described by the equation, that is VA equals to K dot VCO2 by PaCO2, which is known as VA means minute alveolar ventilation, K is a constant, VCO2 is a rate of CO2 production. Now, ventilatory supply versus demand. A normal ventilatory supply greater exceeds ventilatory demand. Physiologically, reserve is maintained. Ventilatory supplies decrease and ventilatory demand increases. And in cases like acute asthma attack, borderline respiratory failure exists, the ventilatory demand exceeds ventilatory supply. In cases like sepsis in a patient with COPD, respiratory muscle fatigue develops a hypercapnic respiratory failure ensures. Now, these are the chart in which you need to keep where the ventilatory supply versus demand is needed. Now, what are the factors that reduces ventilatory supply or increases the ventilatory demand? So these are the factors and these are the clinical examples. The factors would be decreased respiratory muscles like muscle fatigue, then precise atrophy, then malnutrition like electrolyte imbalance, arterial blood pressure abnormalities, fatty infiltration, then unfavorable alteration, then increased muscle energy, then high elastic work of breathing, then decreased motor neuron function, decreased neuromuscular transmission. So you need to remember this chart in which is consistent of the factor that reduces ventilatory supply or increases the ventilatory demand. Now, what are the categories of respiratory failure? Now, there are 4 categories of respiratory failure, that is abnormalities of the central nervous system. First, there are some categories for the respiratory failure. There are abnormalities which you can find in first in the central nervous system, second in the peripheral nervous system or in the chest wall. Third, where the abnormalities is seen in the airways. Fourth, the abnormalities seen in the alveoli. The abnormalities seen in the central nervous system. First, a variety of pharmacological, structural, and metabolic disorder of CNS are characterized by suppression of neural drive to breath that resultant of hypovolemia and hypercapnia, and overdose of a narcotic or the other drugs with sedative properties in the common causes of respiratory failure. While the most striking clinical picture occurs with an acute overdose, long-standing use of some agenda that is methadone may result in a chronic hypercapnia. So this is the first abnormality which you can find in the central nervous system. Then its third causes, that is structural CNS abnormality, that is meningoencephalitis, localized tumor or vascular abnormality of the medulla, or the stroke affecting medullary control center. Then the fifth can be the metabolic degenerament, that is hypercapnic through depression or respiratory control system. For example, severe myxedema, hepatic failure, or advanced uremia. Elevation of PaCO2 is observed in chronic metabolic acidosis, for example, due to diuretic use. Now, the second cause is abnormality seen in the peripheral nervous system or in the chest wall. So the most common neuromuscular cause of hypercapnic respiratory failure are Guillain-Barré syndrome, or myasthenia gravis, or polymyositis, the muscular dystrophies, or ALS. The other causes could be acute poliomyelitis, traumatic spinal cord injury are associated with hypercapnic. Pharmacological causes are hypercapnic and the ICU are frequently encountered. use of depolarizing and non-depolarizing paralyzing agents, particularly with systematic corticosteroid, example in the management of status asthmaticus, cholinergic crisis during therapy of myasthenia gravis. So these are the abnormalities which can cause in the chest wall, which can cause the respiratory failure. Then the administration of amidoglycosides to the patient with myasthenia gravis. Then primary disorders of the chest wall constituent another important category of neuromuscular respiratory failure, like severe kyphoscoliosis, flat chest, extensive thoracoplasty, morbid obesity, massive abdominal distension due to ascites or distended loop of the bowel. Now, the third abnormality which you can find in the airways, that is obstructive diseases of the ways, like in the upper or in the lower, or the common causes of the acute chronic hypercapnia. Example in the upper airways includes acute epiglottis, aspirated foreign body, tracheal tumor, or narrowing of the trachea or glottis by the fibrotic tissue. Disorder of the lower airways includes COPD, asthma, and cystic fibrosis. Some other disorder could be acute asthma, acute exacerbation of COPD, air trapping, and lung hyperinflammation occurs, resulting in diaphragm flattening and worsening diaphragm mechanism, the overall effects in a growing imbalance between ventilatory supply and demand. Now, the last abnormality which causes respiratory failure is the abnormality seen in alveoli. Through diseases characterized by diffuse alveolar filling frequently result in hypoxemic result failure, that is respiratory failure. The common clinical example categories are cardiogenic and non-cardiogenic pulmonary edema first, second the diffuse pneumonia, third the extensive pulmonary hemorrhage, fourth that is aspiration of stomach content, fifth that is near drowning. An extensive acute pulmonary disease characterized by alveolar filling, ventilatory demand is high because of hypoxemic and increase in DV and VT, the elastic work of breathing due to reduced lung compliances, the resistive work of breathing due to the airways narrowing, increased airways reactivity, and the neural drive to breath mediated by the pulmonary parenchymal vagal fibers. And congestion with weighted ventilatory demand, the ventilatory supply reduced because of the alveolar flooding, reduced lung elasticity, respiratory muscle fatigue, and possibly reduce the blood supply to the diaphragm secondary to shock. So this is the mechanism. These are the categories in which there is the abnormality of alveoli, which result in the respiratory failure. And this is how the mechanism works in these conditions. So you have to need to understand the mechanism. In these conditions, these mechanism occurs, which leads to the abnormality in alveolar, which leads to respiratory failure. Now, how? If the person is having a respiratory failure, how you approach to the person? How you approach to the patient? First, you need to see the clinical finding, whether it's an acute one or by the chronic one. Then second, how you're going to confirm it? You need to confirm it by doing the, as soon as possible, you need to do the ABG. Then third, evaluation of underlying causes. Now, how you're going to see the underlying causes, whether it's having a flat chest or something, the abnormality is in the alveoli or in the other things. You need to find out evaluate the cause, the basic cause why the patient is getting into chronic or acute respiratory failure. Then you need to treat the chronic cause. So first you need to see the sign and symptom of the acute respiratory failure. So in the sign and symptom of the acute respiratory failure, you need to go to the underlying diseases. Underlying diseases, the commonly occurring underlying diseases would be hypoxemia, acidemia, and the hyperapnea. Then the localized pulmonary finding would be acute cause of hypoxemia, like example that is pneumonia, pulmonary edema, asthma, and COPD. Then systemic finding could be hypotension and sepsis. The other than thorax, that is other Organ finding could be abdominal pain. It can lead to pancreatitis, leg pain, that is fracture long bone. It can lead to ARDS. These are the conditions which also get included in ARDS. So this is the condition how you're going to approach in the patient if the patient is getting into acute or chronic form of respiratory failure. Now, what are the neurological and cardiovascular signs and symptoms predominant? If the neurological findings which you can see in the respiratory failure patients are restlessness, anxiety, confusion, seizure, coma. Aspect faces that is severe hypercapnia. Now, in the cardiovascular finding, you can see tachycardia and arrhythmia. Then hypoxemia in relation with pulmonary embolism, few or no finding, only dyspnea. Okay. Now, what are the management? That is TRICE decision, airway management, correction of hypoxemia, hypercapnia, and search of underlying cause. So this is how step by step you will do the management in respiratory patient. What is TRICE decision? The first step in the management is to determine the approach setting for the care admission to start the medical management. So to an intensive or immediate to take the patient first, you need to do to take the patient urgently to the intensive or intermittent care unit. Second, the factor that constitute the basis for this decision include the acuity of the respiratory failure, that is degree of hypoxemia, hypercapnia, acidemia, the presence of comorbidity conditions like cardiac diseases, renal insufficiency. At one end of the spectrum, and the patients with fluminant hypoxemia, respiratory failure, metabolic acidosis, and the imminent cardiovascular collapse who need emergent intubation, mechanical ventilation, administration to the critical care unit. At the other end of the spectrum, in the patient with COPD and chronic compensated hypercapnia, respiratory failure who requires observation and intermittent care unit. So first, how you're going to manage this by the TRICE decision. In the TRICE decision, as soon as possible, if the patient is in the respiratory failure, you need to admit the patient in the intensive care unit or in the immediate care unit. Then you need to find out the cause of the respiratory failure, whether the patient is in a degree of hypoxemia, hypercapnia, or acidemia. Then you need to rule out the cause, that cardiac disease or renal insufficiency or having a respiratory cause. Then according to that, you need to put the patient on different kind of treating methods. So that is TRICE decision. Second, the airway management. In the airway management, first you need to assure of an adequate airway is the key, and the patient with the acute respiratory distress when progressive hypoxemia, hypercapnia is observed over the few first minutes or hours in the mechanical ventilation are warranted. In selected patient, use of the non-invasive mechanical ventilation may obviate the need for intubation. Such patient includes like hypercapnia as soon as some with acute hypoxemia, respiratory failure other than ARDS related. Now, contraindication for trial of non-invasive. So, in the airway management, non-invasive ventilations is being needed, but in some contraindication things where non-invasive ventilations are not given. First, that is respiratory arrest. Second, in ill-fitting face mask. Third, hemodynamic or cardiac instability. Fourth, that is patient agitation, swallowing difficulty, excessive respiratory secretion, inability to protect the airways, recent upper airway or upper GI surgery. So you need to keep, these are the contraindications where a non-invasive airway management should not be given in these kind of patients. Now, the correction of the third thing which you can go for is the correction of hypoxemic and hypercapnia. Once the airway is secure, the clinician must turn attention to the treatment of hypoxemia. The life-threatening aspect of acute respiratory insufficiency, the goal is to assure adequate oxygen, generally to achieve with PaO2 about 60 mmHg. In patients who have coronary or cerebrovascular diseases, a slightly higher level of arterial oxygenation may be desirable in order to provide a buffer or for a sudden unpredictable changes in gas exchange. Some patients may simply require nasal or a face mask to achieve an adequate CO2. Others are best treated with controlled flow oxygen delivered via venturi mask. For example, the patient with COPD and chronic hypercapnia. Generally, if an acceptable level of oxygenation as adjusted by arterial blood gases cannot be attained using a face mask, or if the administration of supplemental oxygen causes hypercapnia to worsen significantly. For example, in patients with COPD, mechanical ventilation, invasive or non-invasive, is required. While correcting hypoxemia, the clinician must also address and coexisting hypercapnia and respiratory acidosis. Once again, the immediacy of correction depends on the magnitude of acidosis. A partly compensated respiratory acidosis in a patient with COPD usually constitute a less urgent clinical circumstances that does profound respiratory acidosis in a patient with a drug overdose. Then search for underlying cause. This is the last treatment and the point which you need to remember. Finally, as the therapy is initiated to correct the hypoxemia, hypercapnia, and acidosis of the respiratory failure, the causes of the problem and its management must be undertaken. In some cases, the causes are being straightforward administration of the narcotic antagonist to the patient with the narcotic overdose. In others, more protracted courses may be in stores, long-term ventilator management of human acute respiratory distress syndrome due to sepsis. In both brief and prolonged cases of the respiratory failure, attention to details of management is important in order to minimize the risk of complications of the therapy. Now, how you're going to monitor the patient with acute respiratory failure? For many patients with acute respiratory failure, simple observation of respiratory rate, tidal volume, accessory muscles, and the presence of paroxysmal breathing movement provide evidences for the respiratory failure and the need for intubation and mechanical ventilation. Second, the patient with the asthma or acute exhaustion of COPD with frequently manifested rapidly shallow breathing and thoraco-abdominal breathing movement. Once placed on mechanical ventilation, the patient must be carefully monitored for ventilators associated compliances. Complications like ARDS, pulmonary embolism, pulmonary edema, barotrauma. In the patient with status asthmaticus requiring mechanical ventilation, development of hypotension due to intrinsic positive and expiratory pressure, intrinsic PEP and auto PEP. Now, what are the complications of acute respiratory failure? First, that is the pulmonary cause, the pulmonary embolism, pulmonary barotrauma, which leads to interstitial emphysema, pneumothorax, subcutaneous emphysema, pneumoperitoneum, tension, lung cyst, subpleural air cyst, pulmonary fibrosis. Now, related to the use of mechanical devices, complications used for the use of mechanical devices, that is infection, arterial desaturation, hypertension, barotrauma. Now, what are the complications of insertion and maintenance of pulmonary arterial catheters? First is the pneumothorax, air embolism, then arrhythmia, then infection, thrombosis, pulmonary artery rupture. Now, what are the complications of tracheostomy? Then again, the same pneumothorax, bleeding, tube dislodgement, tracheoimmunitated fistula, tracheoesophageal fistula, then tracheal stenosis. Then what are the complications for tracheal intubation? If you go into a tracheal intubation in the respiratory failure, so the complication would be related to prolonged intubation attempt to hypoxemic brain injury, cardiac arrest, fissure. Related to right brain bronchus intubation, hypoventilation, pneumothorax, atelectasis. Self or inadvertent extubation, endotracheal tube, dislodgement, endotracheal tube, cuff leak, injury to pharynx, larynx, and trachea. Now, the other complications correlevant in the acute respiratory failure to other organs would be gastrointestinal, can to hemorrhage, ileus, diarrhea, including stress. Cardiovascular would be hypotension, arrhythmia, decreased cardiac output, myocardial infarction, pulmonary hypertension. In renal, acute renal failure, fluid retention. In infection, that is nosocomial pneumonia, bacteremia, then sepsis, paranasal sinusitis. Then other could be nutritional. The complications of underlying malnutrition could be decreased respiratory muscle strength. Then immunosuppression, complication of enteral feeding, that is pneumothorax. It can cause pleural effusion, can cause sinusitis, aspiration, diarrhea. Then complication of paranasal feeding, that is pneumothorax, sepsis, hyperglycemia, hypoosmolar coma, hypophosphatemia, liver function test abnormality. Complication of refeeding diaper, that is hypercapnia. The other complication could be psychiatric, that is anxiety, depression, confusion, sleep dysfunction, psychosis. Then hematological, that is anemia and thrombocytopenia. Now, what are the prognosis if a patient is in hypoxemic respiratory failure? The comorbidity and mortality in acute hypoxemic respiratory failure, as expected, mortality in hypoxemic respiratory failure depend on the underlying causes. Mortality in ARDS appears to have improved in the recent years, but it remains high in the patient who are at the age of 85 years, or mortality is 60%. Patient who develops sepsis after trauma has a low mortality than to the patients with sepsis having the complications with the medical disorders. Many patients who survived an episode of ARDS manifested some impairment of pulmonary function, including obstructive and destructive defects and reduction in diffusing capacity 1 or more years after recovery. Now, that is a hypoxemic respiratory failure. Now, morbidity and mortality in acute hypercamic respiratory failure. In general, several parameters are responsible for higher mortality in patients admitted in hypercamic respiratory failure. First parameter, the patient's physiological reserve as determined by the co-current cardiopulmonary, renal, hepatic, neurological diseases, and the patient age. The underlying cause of the acute deterioration, the severity of the respiratory failure defined as the arterial pH and PCO2. Then the development of complication after onset of acute respiratory failure, for example, sepsis, pneumonia, renal failure, gastrointestinal bleeding. For the patient hospitalized by acute exacerbation of COPD, overall mortality is 8% to 12%, but it may be as high as 28% for those with significant comorbidities. Mortality for this group at 1 year is 43%. For the patient with an acute exacerbation of COPD who requires mechanical ventilation, in hospital mortality is higher. 1 year mortality approaches 25% and 5-year mortality is 70%. So according to this, we have studied what we have today completed about what exactly is about the oxygen concentration, how we give the oxygen to the patient, in which manner we can provide oxygen to the patient, and what are the mechanical therapy and how many different manners we can provide the patient oxygen, and what do you mean by acute and chronic respiratory failure? What are the kind of respiratory failure? Further on in the respiratory system, we'll to move on the topic of bronchial asthma. Now we'll to give the overview written on bronchial asthma. What do you exactly mean bronchial asthma? So the bronchial asthma, it's all about the wheeze. It's not the asthma. All asthmatic do not wheeze. Definition of asthma. We have all have actually heard about asthma. Asthma disease when a person is having a lung issue. It's a kind of respiratory illness, which is defined as a chronic inflammatory disorder of airways. Many cells in cellular elements plays a role in chronic inflammation in the asthma. It leads to chronic inflammation, which is associated with the airways, hyperresponsiveness that leads to the recurrent episodes of wheezing, breathlessness, tightness, and coughing. These are the specific symptoms when there is a patient of asthma. There are recurrent episodes like wheezing would be there, breathlessness would be there, chest tightness, and the cough would be there. The widespread, variable, and often reversible airflow limitations are there. Then how you are going to diagnose bronchial asthma? There are some of the questions and some of the clinical features which we're going to find out in the asthmatic patient. Now, the first would be the clinical diagnosis of asthma made by the symptoms of episodic breathlessness. A person is going to have the episodes of breathlessness. Then wheezing, a person will going to feel tightness in the chest. Then a cough presentation could be sometimes mostly dry and sometimes in a wet form. Then the second could be measurement of lung function by spirometers, peak flow meters, provide information of the severity, reversibility, and utility of airflow obstruction, and help to confirm diagnosis asthma. Then the third point would be extra measures may be required to diagnose asthma in children more than 5 years, elderly, and occupation asthma. The fifth point would be measurement of allergic status can help to identify the risk factor that causes asthma in individual patients. For patients with the symptoms consistent with asthma, but normal lung function should be there. Measurement of airway hyperresponsiveness may help confirm the diagnosis. Now, in the asthma patient, what are the factors, facts, what are the and figures over the world? Now, according to the classification of asthma severity on the NAP classification, according to symptoms, we can see they are divided into 4 categories. First, that is mild incident, mild persistent, moderate persistent, and severely persistent. So, the highest range we can in the children, that is like 1%, that is mild intermittent. Then that is presented in the children. Then in the egg, that is 34%. And then total ratio we can find that is 39, that is mild intermittent. In the mild persistent, we can see in total that is 15%. Adults, they are presented 24%. Then in children, it is only presented 15%. So there are different kind of graphs they have calculated up into the NAP classification of asthma severity, which is found in the children and adults. So in total, the higher ratio of asthma severity is found in the mild intermittent form. Now, asthma emergency department. So we have seen the highest ratio in the population above the ages in the population 2000 in the year 2000 population, that is 104. So the 104 people, they are mostly in the category of mild intermittent asthmatic patients. Now, asthma hospitalization to the, as we can say in this year 2015, again there are 30% of the people who are adjusted to the hospitalization who are having the cause of asthma. In the same epidemiology of asthma and COPD, we can see what is the estimated number of obstructive airway disease patients in India. So there are 35 million of people who have from asthma. This is a study in 2003. There is increased rate of asthma in comparison to COPD. There is more asthmatic patients in India, that is 35 million in comparison to COPD patients. There is only 2.2 million of patients of COPD suffering than in comparison to asthma, which was in the year of 2006, there were only 28 million of people who were suffering from asthma and the 17 million people they were suffering from COPD. In the recent years, as we are keep doing the further on study, we can see there always increase in the high increase of asthmatic patients than in comparison of the COPD patients. Now, the estimated prevalence rate of the chronic asthma by the age. Now, as you can see in the urban areas, so basically a research progress by the asthma by the age related. So the people more than the age of 15 years, the age between the 15 and 59 years, and up the age of 60 and above. So you can see how many people are getting affected in the rural and in the urban areas. How many people are there who can get the total number of people who get affected due to asthma. Now, the difference of acute asthma in different age groups. Now, the people are less than 15 years, that is only 19-25% of people are there. The age between 15 to 59, that is 40% of people are there who got affected by asthma. And the people of the age 60 and equivalent more than 60, that is 107 of people are there who are affected by acute asthma. Then current cost of treatment of asthma per age, according to this by the study 1996 to 2016, you can see there is a chronic mild asthma, chronic moderate and severe. That's the kind of treatment which we give to the asthma, and the treatment of the asthma with their severity, the kind of mild, moderate severity, according to their treatment, that is being divided according to their classification. The person who needs the hospitalization can get treated at home also, and the regular intervals. So these are the number of graphs which we can see as per year. Now, what is the mechanism of asthma? As being known as it's a chronic inflammation. So, in the mechanism of asthma, that is leukotriene-2 and cytokinase leads to the environmental agents inflammatory stress. Now, the environmental agent, the increased cell products consistent of inhibition, mucus, fibroblastomas, and amplification, which leads to the propagation of blood from smooth muscle, which leads to the epidural myasthenia, trophitic unit, and asthma, that is contraction, interleukins A and pro-inflammatory mediators, which leads to the inflammation of the cells, mast cells, eosinophils, rays, and neutrophils, in which ventricle cells are also being inflamed. So, in the mechanism of asthma, everything reacts together. Th2, Th1, cytokinase, it leads to the environmental agent, that is compile of the inflammatories, which affects the propagation. Then this also affects the cytokine, which is with the concept of pro-inflammatory mediator, which affects the mast cells, eosinophils, and neutrophils, basically causes the inflammation, and in which they also involve dendritic cells too. So that is basically the mechanism of asthma. Now, the mechanism underlying the definition of asthma. First, the risk factor. According to risk factor for the development of asthma, so what exactly is the risk factor? The risk factor is the inflammation. And then there would be the airways hyperresponsiveness, which leads to the airflow obstruction, then the markers, then there is a factor for the exuberance. Exuberation means there would be the increased risk in the factors, then there is more and more inflammation of the muscles, then the interleukotriene pro-inflammatory cells, they increase in the inflammatory to the mast cells and to the, if you call it as mast cells and what call it as, they all together to this inflammation. Then the symptoms we already know, that is chest tightness, then the breathless, coughing, could be the dry cough, sometimes the wet cough, they all lead to the asthma. Then asthma inflammation cells and mediators. Now, what are the cells and mediators? So here is a cycle which shows what are cells and the mediators. So over here, the elements are here. First, There is a mast cell distribution in between. Allergens, they are divided into two, that is mast cells and the macrophage and dendritic cells. Then the mast cells are divided into, that is neutrophils and eosinophils. Macrophages and dendritic cells, they are divided into two again, Th2 cells and the eosinophils again. Then they all together, they form mucus plug. By the macrophages and dendritic cells, they shoot Th2 cells. From there, the mucus plug is affected by the eosinophil. They affect the epithelial shading, and where the nerve activation is occurs. They overall together, they affect the mucus hypersecretion, hyperexia, vasodilation of new vessels occurs, angiogenesis occurs, and the plasma leakages and supraepithelial fibrosis occurs, which is the sensory nerve activation, polygenoplex, and bronchoconstriction like hypertrophy and aplasia occurs. Now, what are mediators? The mediators which affects, which act as a pro-inflammatory for causing asthma or for causing inflammation, chronic inflammation, which tends to asthma. The mediators are LTB4, MCPL1, MIPLA, ILA, GROA, IgG, GM-CSF, TNFA, ROS, NO, endothelin, TGFB. Then the effects are these are the mediators which leads to the effect of mucus hypersecretion, fibrosis, alveolar wall destruction. Then from there, it leads to the proteinases, that is neutrophil lactases, catapenesis, proteinase 3, MPPase. Over there, the cycle, macrophage and neutrophils, lymphocytes, eosinophils, epithelial cells, endothelial cells, and fibroblasts. So basically over here, the mediators are the main pro-inflators, which was inflammation, and they affect over the mediator like CB4, MCP1, MP1A, ILA, GROA, IP10, GM-CSF, NFA, ROS, NO, endothelin, TGFB. These are the basic main mediators which leads to macrophages, neutrophils, T lymphocytes, epithelial cells, endothelial cells, fibroblasts, nitrogenases, neutrophil elastase, catapenesis, neutropenases, MPPS. They all together give effects of mucus hypersecretion, fibrosis, alveolar wall destruction. Now, over here, we can see the picture of the epithelial cells. Now, this is epithelium of a cell. And here the muscle cells presented, and here is the mucus. This is the normal airway. Now, over when there is asthma, now this is the asthmatic airway. Now, this is the normal airway, and this is asthmatic in a patient who is suffering from asthma. So, this is the asthmatic airway. You can see. So, there are normal muscle conditions. Now, this is the airway edema developed. Over here, you cannot see any airway edema. Over here, at the border of epithelial, you can see the airway edema is being developed. Over here, you can see the airflow recruitment. Over here, which you cannot see, that in the blood, when you give a patient CBC sample, in the CBC sample, you can see there would be increase in the eosinophil counts too. Then there would be decrease of the toxic protein. Over here, there is no increase in the toxic protein at the border of epithelial borders, which result in the epithelial damage. When there is release in the assimilation, when there is release in the toxin protein, it's release in the epithelial damage. You can see there is a breakage of epithelial from borders. From the normal airways, you can see there is a breakage of epithelial. That is due to the toxin protein product, which leads to the epithelial damage in the asthmatic patient, which in the normal airways, a normal patient, you cannot find it out. Then there is the secretion of mucus. Now, all these things occur due to the intermittent factors like NO, GPO, then endocrine factor A, So these are the intermediate factors which lead to all this asthma airway destruction. Now, what is the mechanism in asthma inflammation? Now, the mechanism, allergens, sensitizer, viruses, air pollutants. These are the basic things which can lead to asthma inflammation. Now, allergens, sensitizer, viruses, air pollutants, it can lead to the inflammation, chronic inflammation, eosinophilic bronchitis, which leads to two things, that is airway hyper responsiveness. Second, the symptoms which occurs that cough, chest tightness, wheeze, and dyspnea. Then the airway hyper responsiveness, they trigger, that is allergens, exercise, cold air, saturation, particulate. So this is the mechanism occurs in asthma inflammation. What are asthma inflammation cell and mediators? We have already seen. What are the asthma inflammation and mediators? The asthma and inflammatory are the inflammatory cells which get inflamed, that mast cells, eosinophils, Th2, basophils, neutrophils, basophils. Now the cells which get damaged in asthma, that is epithelial cells, which is presented at the border, as we have already seen in the normal tissue, that is epithelial cells, smooth muscles, endothelial cells, fibroblasts, and nerve. Now the mediators which have been affect them, that is histamine, leukotrienes, stenoids, F50, kinins, adenosine, endothelins, nitric oxide, cytokines, chemokines, growth factors. These are the mediators which is being released. These are toxin products which is being released by the mediator, and they affect like bronchospasm, plasma exudation, mucus secretion, AHR, structural changes. So these are the cells which get affected. These are mediators, and they lead to these are the asthma. So what are leukotrienes in pathophysiology of asthma? Leukotrienes in asthma. Potent sites and effects of the systemic leukotriene. Now, this is the structure, the leukotriene action on airway structure. As you can see that structure very clearly, the leukotrienes, as we know, they are the pro-inflammatory mediators, right? Though these are the pro-technical sites and the effectors systemic leukotriene, which is we also called as a IA, that is leukotriene. So we can see there's a endometrial thickening and the border. So here is the systemic leukotriene, the mediator, the pro-inflammatory, can infect their blood vessels with cause edema. Over here, you can see the increased mucus secretion, which can cause hyper-responsiveness. This is air is epithelium, which decrease. If there's increase in the mucus secretion, then it leads to decreased mucus transport, which leads to the eosinophils recruitment, which leads to epithelial protein and epithelial damage. Why there is epithelial cell damage? Due to the protein toxicity, which leads to the epithelial cell damage, which we have already seen in asthmatic cells in the last show and the previous picture which I have showed you in the before slide. Then over there, when there is breakage in the epithelial cell damage, then it leads to the increase of tachykinase and the steady C fibers and the smooth fiber, they get contracted and the proliferation. So this is how the leukotrienes act in the pathophysiology of asthma. So basically, leukotrienes are the pathophysiology of asthma. Now, this is how in the written form that is by the diagrammatic form, and this is in the written form. So in the first order, the membrane of phospholipid, that is phospholipid A, intermittent fat, alkanotic acid with flap. Both leads to the cyclooxygenase and 5-lipogenase. 5-lipoglycogenase activating protein that is called as flap. Cyclooxygenase, they lead to the prostaglandin and thromboxane. and they file lipoglycanase and file lipooxygenase activating protein, which is called as PLAB, leads to LPA4. LPA4 is subdivided into LC4 and LCA4. Now, then LCA4, which is subdivided into LPC4 and LCA4 again. Now, LCA4, which is again subdivided into hydrolyzed, which get hydrolyzed, leads to leukotriene B4. And then L4, which is divided into leukotriene C due to LPC4, synthesizes leukotriene C4, and which leads to wide domain transthyropeptidase, leukotrienase B4, ditidase, and leukotriene E4 is formed. So this is cyclooxygenase pathway and 5-hypoxygenase pathway. So this is basically a pathophysiology of leukotrienes, which act in asthma. So we need to remember how leukotrienes work in asthmatic patients. Now, the essential diagnosis in asthma, we always make, there is very different kind of diagnosis in respiratory illness. As they have common signs and symptoms we can see, but there are different kind of BDs presented. As we see in correlation or same time, there are other kind of BD can also be formed. Like one could be a COPD. Second, LVR, that is left ventricular failure, could be a asthma, then localized narrowing of the major airway tumor or tracheal process. Then fourth could be the functional obstruction of upper airway, especially in young women, which is to be as a hyperventilation syndrome and panic attack. Then fifth could be the vocal cord dysfunction. Now, that is, they were the DDs which can be found in or which can think in the arteries. Now, these are the DDs which can be thinking. Now, in the children, we can think of chronic sinusitis, then gastroesophageal diseases, then tuberculosis, cystic fibrosis, biliary dyskinesia, foreign body aspiration, congenital malformation, and anomalies of the respiratory tract, then congenital heart diseases. So these are the things we can really see in the patient. So basically today we have actually learned about asthma. What is asthma and how asthma is being formed? Basically, what are the mediators, what are the pre-inflammatory mediators which damage the epithelial cells due to which the edema forms, and due to edema, which are the main inflammatory factors mediate which affect the cells and which break the epithelial factors. So we have studied about it. Now the first topic we have taken is asthma. The second respiratory illness today we're going to study of lung abscess. What do you mean by lung abscess? Lung abscess is a kind of localized area which is to be as a destruction of lung parenchyma due to infection by pyogenic organisms characterized by tissue necrosis, suppression resulting in the cavity more than 2 centimeters in the diameter, formation filled by the narcotic debris. The lung abscess was a devastating disease in the pre-antibiotic era when 1/3 of the patient died, another 1/3 recovered, and the remaining developed the debilitating illness. For example, recurrent abscess, scarring emphysema, and bronchiectasis. Now there are classification of the major classification of lung abscess, primary and secondary. The primary lung abscess is more than 80% cases usually arises from aspiration caused principally by the anaerobic bacteria. Occurs in the absence of underlying pulmonary and systemic conditions. The second lung abscess, it arises in the setting of underlying conditions such as a port, obstructive progress, example of bronchial foreign body tumor, or the extrapulmonary site or progress. Like for example, in the patient of HIV infection or immunocompromised condition. The lung abscess can also be classified as acute and chronic. So the secondary lung abscess, they again get subclassified as acute and chronic. So in the acute, it's more than 4 to 6 weeks in the duration, and chronic is more than 40% of the case. Now, what is the etiology of lung abscess? So the primary lung abscess etiology is again divided into primary and secondary types. So primary lung abscess, first, the factor predisposing to the aspiration. Like, for example, dental caries, impairment, confusionness due to anesthesia, stroke, cerebral accident, seizures, including episode stage, head trauma, alcohol intoxication, drug overdose or abuse, narcotics, debtors, metabolic encephalopathy, neuromuscular diseases, impaired laryngeal closure, clogged tracheal tube, tracheostomy tube, recurrent laryngeal nerve palsy. Now, the second cause could be esophageal disorders like asphyxia and other dysmortality syndrome, gastroesophageal refluxes, strictures, benign or malignant, Zenker's diverticulum. Now, secondary lung abscess could be occurred in the bronchial obstruction, could be tumor, foreign body, or enlarged lymph nodes. Second could be with coexisting lung disease like bronchitis, buccal emphysema, cystic fibrosis, infected pulmonary infarct, lung confusion, spreading from extrapulmonary sites, metagenous abdominal sepsis, infected endocarditis, infected cannula or central venous septic thromboembolism, is spreading like bronchial esophageal fistula, subphrenic abscess. So what the pathogenesis of lung abscess? The development of primary lung abscess is through originating anaerobic bacteria from esophageal and the gingival cervix are aspirated in the lung parenchyma is a substantial host. The pneumonitis develops initially over a period of 7 to 14 days. The anaerobic bacteria, basically, what we can see is the primary lung abscess. They are originated from the anaerobic bacteria from the oropharyngeal. They are aspirated in the lung parenchyma within the period of duration of 7 to 14 days. Then they have been produced, the parenchyma and the cavitation is being produced by those extended can to the host pathogen interact. The disorder begins as a necrotizing bronchopneumonia. So, you see by the oropharynx, the anaerobic bacteria that come from the oropharynx and they get aspirated the lung parenchyma. Then they for the period of 7 to 14 days and they develop pneumonitis. Then they become the host pathogenesis interaction and they form a necrotizing agent over there, form bronchopneumonia over there. Then they detent as a necrotized segment and they proceed to process a cavity abscess communicating with the adjacent airways. Then microscopically, the wall of the lung abscess is irregular with saggy fibrinous lining. They're not having any regular shape or size and they are literally saggy. They surrounded the cavity shows an acute and organizing bronchitis. So this is basically the pathological cycle, a pathology cycle, how the primary lung abscess is developed. So this is the saggy pulpic primary lung abscess you can see. This is the sagittal section of the lung with the abscess, primary lung abscess is being developed. As you can see, this is the saggy lung abscess part. Okay. A pneumonetic patch is being developed. This is the CT and this is the X-ray of the radial demonstration you can see. Now, microbiology. In the microbiology, in this 75% of all the lung abscess, they are located in the superior segment of the upper lower lobe or in the apical segment of the lower of the both lungs, caused by a wide variety of different organisms and in 90% caused by the polymicrobial culture rate. Anaerobic organisms are most commonly implicated, like gram-negative anaerobic like bacteriotypes like Botulella and Cystobacterium capsulatum and Necrophorium. Gram-positive anaerobic anaerobe are Peptostreptococcus and Goldia, then micro-anaerobic streptococcus. Then anaerobics like Streptococcus aureus, including methicillin as anaerobic, Staphylococcus pyogenes, Klebsiella pneumonia, Pseudomonas, then Haemophilus influenza type B, Acetobacter, Enterococcus lignola, Staphylococcus aureus. Staphylo the most common organism causing lung abscess in this children. So you have to remember, like anaerobes are the most commonest organisms which need to cause lung abscess. It could be the negative anaerobe and the positive anaerobe. But Staphylo is the most commonest organism which causes lung abscess in children. Now, other microbes are Mycobacterium such as Aspergillus, Streptococcus, Blastomyces, Cochleoides, Entomobilus, Histoplasma, then Actinomyces, and Asterobes. These are the other anaerobes, anaerobes which is to causing this lung abscess. Now, clinical manifestations. The clinical manifestations would be the clinical features we find in the lung abscess patients would be usually prolonged in time, 2 weeks to 3 months or more. Indolent courses like include the final symptoms which we really found in the lung abscess patient could be fever, night sweat, cough with foul sputum, dyspnea, chest pain, weight loss, malaria, and sometimes hemoptysis, clubbing. Clinical findings of concomitant consultation may be presented. Example, decreased breath soundness, percussion, bronchial breakdown, courses, inhalatory crackles. Now, in the imaging, we can, in the chest imaging, you can see vesicle, chest radiographic appearance of lung abscess is an irregular shaped cavity with an air fluid level. Similar chest radiographs may be needed to follow the relation of diseases. Anaerobic technique suggested by the rapid pulmonary cavitation. CT is the most sensitive and the specific imaging modality. The diagnosis of lung abscess. Prasad should be administered as enables the identification of the abscess margin, which can otherwise blind with around corrugated lung. Abscess varies in size and generally rounded in shape. In dense segmental coloration, they may contain only fluid or have gas levels. Now, the lab study and further work. Now, you can, in the lab study, you can see the leukocytes, sputum for the gram stain, AB stain and culture sensitivity. Then you can sputum for the serum IgG levels, fungal serology. These are the tests. These are the tests you can, by which you can find out about the lung abscess. The fungal serology, then the blood culture for the assessment for the parasitic infestation, and transtracheal aspirated, city guided, thoracic needle aspirated, then fibro-optic bronchoscopy with protect brush, then bronchoalveolar lavage. Then what are the differential diagnoses of lung abscess? Excavating bronchial carcinoma is squamous, cellular, and microcellular. Excavating tuberculosis, then lower pleural emphysema, infected emphysematous bulla, then cavity pneumoconiosis, hiatus, pulmonary hematoma, little cyst of lung, cavitary infarct of lung, Wagner's granulomatoma. What are the applications which has been developed due to lung abscess? That is emphysema, pleural fibrosis, trapped lung, respiratory failure, then bronchopulmonary fistula, then percutaneous, then fistula. So what basically the treatment when a person is there with the lung abscess, what are the basic and the major treatments which you advise your time of lung abscess development? So the treatment for the abscess must be guided microbiologically and knowledge of any underlying or associated condition that may be predisposed to the development of severe pulmonary infection. 90% of cases of small and non-progressive cavity is an otherwise healthy person response to conservative and antibiotic management. Combination of B-lactam and B-lactamine inhibitor, imipenem or meropenem, flunicin, and moxifloxacin. Duration dependent on the clinical and radiographic response of the patient. Patient should be treated active until fever putrid sputum fluid can resolve. And any fluid collection has resolved or stabilized typically over 2 to 3 weeks or more than this. The intervention and surgery. If not get resolved by the supportive management by antibiotic therapy, then you go for the intervention and the surgical processes. That is bronchoscopic drainage for the abscess. With critically ill patients, air fluid level, bronchial obstruction. Now, what are the indications if you plan for the surgery? The indication for the surgery should be segmentectomy and lobectomy. The poor response to the antibiotics, large abscess more than 6 centimeters, residual lung function in BP scan of pneumatic region, lung infarction, air obstruction limiting drainage due to tumor or foreign body. So this is what we have heard about lung abscess. So we need to remember that exactly is about the lung abscess, what is primary lung abscess, what is secondary lung abscess, what are the clear manifestation of lung abscess, and what are the causes for the anaerobe and microorganisms which lead to the lung abscess. First, how they enter to the lungs and how they form the like saggy annular shape of abscess and how they are developed. First, they form the pneumonia and they form pneumonitis within the duration of 7 to 14 days. Then in the treatment, we need to remember that we need to give the supportive therapy that is used by the antibiotic. If the patient do not respond to antibiotic and it's really critical, they go for the segmento bronchoscopy surgical manner. And you can only see the patient is really critical and very poor responsive to the antibiotic, then we go for the surgical manner. The third topic we're going to study today is about bronchiectasis. What exactly mean by bronchiectasis? It's also a kind of lung respiratory illness. Bronchiectasis, it is defined as abnormal, irreversible dilatation of bronchi. So in this, the end stage of variety of pathologic process that causes destruction of bronchial wall and it is surrounding the tissue. So this is normal bronchi and this is bronchiectasis. So this is the normal bronchial walls and this is the infected bronchial which leads to bronchiectasis. So this is the normal bronchi. As you can see, there is no dilatation, but at home you can see in the alveoli, you can see the dilatation present, which is called as bronchiectasis. Over here inside the cell walls, the epithelial walls get damaged and there is increased mucosa. Over here, the normal epithelial cells are normal, mucus is normal. So this is the real structure, the basic structure of the lungs. Inside the lungs, over the normal lungs, there is no dilatation alveoli present, but in the bronchiectasis lung, the dilatation is present, there is the increase in the mucus presented, then there is damage of the cell wall and the epithelial is presented. So what is the etiology of bronchiectasis? The etiology of bronchiectasis is it's prior to the infection, then systemic inflammatory disorder, genetic disorder of the host defense, idiopathic in 50% of the patients. Now the pathophysiology, basic Mainly, the basic pathophysiology is not known in many cases, may vary with etiology. Gross the chronic changes so that initial changes of injury proposed to lead to initial airway obstruction are not often observed. It affects mostly medium size of bronchi, but typically extended to the disc bronchi and bronchioles. On surgical resected outside lungs, affected bronchi and bronchioles are so prominent, visible all over the surface. Dilated and active bronchi, commonly filled with the purulent secretion. Affected bronchi shows transmural invasion, mucous edema, getting ulceration, neovascularization, polyploidal appearance of the bronchial occlusion. These are the changes which you can find in the bronchial section, bronchi section. Then the degenerating which you can find out, that is glomerulation, then lymphoid aggression, rising, that is the smooth muscle hypertrophy, pitting, that is bronchmucous gland. Now, in the microscopy, you can find out airway apicular remodeling, that is mucus cell metaplasia, and leads to decrease in ciliated cells, a region that is cuboid and mucus metaplasia. Now, intense inflammation of bronchial walls, neutrophils, lymphocytes, and monocytes. Then hypertrophy of bronchial glands and mid hyperplasia. This is in the microscopy. When you take a part of bronchi and bronchial, you can see these changes in the microscopy. Now, this is bronchiectasis. This is the pathology. You can see these are the picture as is seen in the bronchial changes and in the normal cell. So this is ciliated cell in the bronchiectasis. This is the ciliated cell. Then lymphos inflammatory epithelium. Over here, there is no inflammation changes of the epithelial cells are seen. There is no inflammation. The lymphocyte inflammation submucosa. Over there is no lymphocyte infiltrating submucosa. Then the blood vessels with endothelial cells are not properly seen. Over there, completely normal in size. Now, in the normal picture of bronchi, you can see the cell is completely healthy and normal. The alveolus is normal, bronchioles are normal, and muscles are into. But in the bronchial spaces, how the process is formed over here in the terminal bronchioles, you can see a shaggy part and the fibrous part. The dilated airways near the endothelial borderline, you can see the dilated airways, inflammation, and fibrotic over here. So these are the changes when you see a cell, a part of a bronchial cell, you can see the clip and a normal cell and the bronchitis cell. Now, phenomena of the bronchitis. The explanation, what exactly is the phenomena of this? The explanation, airways proximal to collapse are strong and dilating force. Difference in the atmospheric pressure in bronchi and the negative pressure in pleural space, which leads to these forces weaken the inflamed airways, permanent pathological dilatation of. Now, what are the clinical stages which occur in bronchiectasis? Classification, the classical clinical features would be cough and sputum. The most basic classical clinical features would be cough and sputum. Cough may be only symptom for many years. It could be a long-term symptom. Sputum could be purulent, tenacious, frequently worse in the morning, accumulated in the night. Okay. Now, you can, in the TB patient, you have seen the sputum. There's no specific timing in the TB patient. They can have sputum when they cough. But in the bronchitis patient, you can have the purulent, tenacious kind of a sputum presented, frequently in the morning because they have accumulated in them. Then affected by the recurrent effect, recurrent infection. If there is a recurrent lung infection, so they get more frequent. Then bronchial plugging, then antibiotic therapy. Now, term is dry bronchiectasis leads to increase in cough, and there is no cough. There is no sputum. May or may not presented with hemostasis. That is 50 to 70. It's not necessary it being the term is presented with blood or with blood. It can happen in 40 to 70%. Then blood sees large clotting. But in some patients there would be blood, and some patients there won't be any blood with sputum. Now, the hallmark symptoms of acute expectorations are cough, dyspnea, volume, darkening of sputum color, fever, hemoptysis, chest pain. Kindly remember all the hallmark clinical features for bronchiectasis. These are the 7 hallmark symptoms of acute exhalation. That is cough, dyspnea, volume, darkening of sputum color, fever, hemoptysis. Now, when the patient going to come to you, the patient will be presented with the history of recurrent chest infection, history, single episode of pneumonia, tuberculosis, produced with secondary pneumonia may result in bronchitis. Now, in the physical examination, you're going to, in the inspection, you're going to note clubbing, hypertrophic pulmonary osteoarthropathy. Auscultation, you're going to, while oscillating the phone, you'll find out the crackle sound in mid-inspiratory and early. Then bronchi in diffused area, then prolonged expiration. Okay, while the auscultation, you will find these hallmark sound. Then in the severe cases, you're going to sound the bronchial breath sound in the complicated pneumonia. In the advanced cases, you're going to sound out the respiratory efficiency or cor pulmonale. Now, the predisposing factors associated with bronchitis, they are the previous bronchial damage as the post-infection, secondary to the child RTI, which include pneumonia, pertussis, complicated use, tuberculosis, which can lead to bronchiectasis. Now, the post-infection cases, which is earlier, focus shift towards extrinsic host defensive reasons. Due to the immunization and antibiotic use, more series from the rectal centers identified and association contributing causes in the approximate percent of the patient. Now you can see the age, this is a graph which really shows the comparison between the patient's age and the etiological factors which can lead to the bronchiectasis. The number of patients, the age, and how much the patients are affected due to bronchiectasis, and some the etiological conditions in which the patients are more affected due to bronchiectasis, like conditions like immunodeficiency, post-infection, aspiration, primary ciliary kinase, alpha-1 antitrypsin deficiency, congenital structure malformation, allergic bronchopulmonary aspergillosis, asthma, rheumatoid arthritis, hematological stem cell transplantation, inflammatory bowel disease, idiopathic. Now, infections. A number of pulmonary infections stem from bronchiectasis. Complicating secondary infection infects with adenovirus, herpes virus, staphylococcus or Klebsiella pneumonia, Pseudomonas aspergillosis. They are contributed to the severity of necrotizing bronchopneumonia. Then streptococcus pneumonia, hemophilus pneumonia, influenza, Klebsiella infection. They are not causing bronchiectasis but clinically presented with bronchiectatic airways. Tuberculosis and non-tubercular bacteria also association with bronchiectasis. Bronchial obstruction means localized bronchitis may also seen in middle syndrome and is also caused by interluminal or extraluminal obstruction, secondary to tumor and NL. The aspiration and inhalation airway injury. Aspiration and inhalation of foreign matter, particularly noxious articulated matter in airways may result in bronchitis. Aspiration or reflux materials from gut also cause airway. Bronchiectasis seen after a few years of aspiration of foreign body. What is cystic fibrosis? Cystic fibrosis comes the most commonest type of bronchiectasis. That is the autosomal recessive monogenetic disorder, which is presented in childhood as multi-system disease. Diagnostic clinical feature and clinical criteria is sweat chloride, C chloride, that is 40 to 60 molecular liter. Now, primary ciliary dyskinesia. The defect in motile cilia peg is 1 is to 20,000 to 1 is to 100,000. Menace of chronic otitis, rhinosinusitis, and infertility. Carter's syndrome, that is tried. Carter's invert and bronchiectasis and the sinusitis. COPD and bronchitis. Cigarette smoking causes COPD, but is probably not etiology of bronchitis. ATP antitrypsin deficiency. So ATP alpha antitrypsin deficiency abundantly increased elastic airways cause restriction of emphysema ADDP. ADP alexin bronchopulmonary based on the histopathology. Cause of pulmonary cause of ATP allergic bronchopulmonary aspergillosis caused by Aspergillus fumigator. Excess mucus production and their mucociliary clearance allow in conidia of aspergillosis, characterized by marked local and systemic eosinophilia, specifically antibiotic IgA and IgE. ADPF patient has the difficult to control recurring episodes of asthma, that is pulmonary infiltrates and central bronchiectasis, that may progress with fibrosis. The inflammatory disorders. The inflammatory and fibrotic cells affect the large and small airways, seen rheumatic arthritis, Jones syndrome, relapses for polychondritis. They are complicated by bronchitis, ulcerative colitis, that is IBD, also associated with bronchitis. Now, the diagnosis is based upon his clinical features and radiological features. After confirming diagnosis with chest imaging, CBC with differential or eosinophilia, serum immunoglobulins, IgE, IA, IgM, sweat chloride, genetic cystic fibrosis test, few culture for bacteria, mycobacteria, and fungus. And this is the clinical approach patient with the suspected bronchitis. So first we need to take the history for the recurrent lower or upper respiratory tract infection, pneumonia, daily mucopurulence sputum products, initial study which relevant to the CD with differential, then chest X-ray, immunoglobulins, then sputum bacterial culture, sensitive mycobacterium fungi. Then come the diagnosis, that is chest CT. A study would be like bronchoscopy, nasal nitroxide, alpha-1 antitrypsin, phenotype, then serum antibody response. These are the clinical approaches which is suspecting a patient for with the bronchitis. Now, in the chest X-ray, if the patient is suspected by the bronchitis, these are the abnormalities which will going to end in the chest X-ray. First, that is increased in the remarking ring-like structure, that is epistasis, dilated and thickened airways, that is sham line, mucus slugging, that is finger and glove appearance. Node X-ray may be normal in bronchitis. Then in the HRCT is closed, high accuracy, localized, described as parenchymal abnormality, mucus sludge, focal area of air traffic, small airway diseases, airway dilatation seen in cross-section, are lumen diameter more than 1.5 times of the adjacent vessels indicate this case. Bronchial wall thickness, small airway flooding with debris, string in birth, distribution and pattern implies causes of bronchitis. Exam, bilateral upper lung bronchitis, max seen in CP, APA, sequence of TB, middle of distribution with ground glass nodules, not seen. HRCT scoring system CF, development to identify disease. In elder stage, grade, severity, monitor disease progress. Now, this is the site, ring size. This is a ring size, kind of the same with the HRCT of chest. If the person is suffering from bronchiectasis, this is a ring sign which you can see in bronchiectasis. And tram-like sign, this is the sign of tram, which you can see in the HRCT picture. Now, what are the classification of bronchiectasis? Classification of bronchiectasis that is basically divided into three kinds, that is cylindric bronchiectasis, secular bronchiectasis, and varicose bronchiectasis. This is the secular one, this is the cylindrical one. Dilated and thickened airways and tree inward. This is the varicose one. Brick score. This is a kind of scoring which basically taken in bronchiectasis. Now, PFT usually in the bronchiectasis patient, if the patient is suffering from bronchiectasis, so the pulmonary function tests are usually found out to be the degree of impairment depends not only on the nature and extent of the morphological abnormal of bronchiectasis, but also on the presence and absence of associated COPD. Patients with mild localized bronchiectasis with no chronic bronchiectasis, no lung function test, spirometry will show pattern airflow obstruction with normal decrease FVC, forced vital capacity, decreased FEV1, that is forced expiratory volume, and decreased FEV with ratio of FVC ratio. Other methods would be lung clearance index used in CF for early detection. It is more sensitive than spirometry. Now, in the microbiology, the sputum of the patient with bronchiectasis is frequently found to be colonized and potentially pathogenic organisms. Microorganisms like Echinenza, S. pneumonia, and Aspergillosis, more severely impaired of lung function, more inflammatory response. This is the bronchiectasis severity index. As you need to, if a person is suffering from bronchiectasis, then you need to remember about this. You need to remember about this severity chart about the bronchiectasis, how you need to evaluate about the patient who is suffering bronchiectasis, if you can. Now, the treatment, again, this is treatment management. The treatment is divided into different treatment understanding, that is management of funding causes, controlling infection, reduce inflammation, improve bronchial hygiene, surgical resection of focal bronchiectasis segments and lobes. This is a general overview of bronchial management. So you need, if you want to go for the management, this is the general management chart. You need to understand this chart. Kind go through this chart, how you can manage the bronchiectasis phase. First, control of infection, the major role. Reduce the bacterial load with the associated inflammatory mediator. This is important for the therapy. Antibiotics are used to treat acute exacerbation. Antibiotics are given for the pathogens like S. influenza or U. Oral fluoroquinolones initially used like ciprofloxacin, moxifloxacin, except for 10 to 14 days. If failure of frequent exfiltration occurs, sputum culture and sensitivity test. Definite antibiotic section. Example, severe exfiltration, IV pseudomonas antibiotic, and potential hospitalization is needed. Prophylactic antibiotic used in controversial but suppressive antibiotics includes daily antibiotics given for 1 to 2 weeks each month, use of daily, twice weekly, thrice weekly. Macrolide like azithromycin, used as biologic response modifiers into fibrosis, diffuse brocyclotic has grown bronchiectasis. Now, this is the first new isolation of argues how you can give the treatment and then if the person in bronchitis is affected by P argues. Now, study trials that are embraces trial batch trial, azithromycin or reduced exacerbation as compared with placebo. However, no significant differences seen in lung function. Blood azithromycin, azithromycin production in no number of observations but sequence. Antitic aerosols, tobramycin 300 nebulized twice daily, and azithromycin 75 mg twice daily effective in cystic fibrosis. NM-associated bronchiectasis should be considered in patients not responding to antibacterial therapy. ABPA corn to all oral prednisolone, that is 0.5 to 1 mg per kg per day. Anti-hunger azole, itraconazole 400 mg per day for 2 months, then 200 mg per day. Voriconazole 300 mg per day. Bronchohygiene, that is problem query, airway proposal clearance, traditional method, postural drainage, autogenic drainage, chemical vibrations with ultrasonic devices, positive expiratory pressure, flower valve device. This is physiotherapy when the person is having during inspiration and expiration, there is no airway airflow, then with this physiotherapy, how you need if the expiratory flow modification, intensity technique, then the positioning, then the exercise. You need to understand the exercise interval, how much the exercise is needed, the patient attendant should be counseled by the therapist, in which manner the person physiotherapy, therapy and exercises should be given. Then mucus clearance. In the mucus clearance, maintain hydrate with oral or IV fluid, prevent mucus retention, humidification of inhaled air and oxygen, nebulize normal and hypertonic saline. Caution bronchospasm may occur with these agents. Bronchodilators like beta-agonists, anticonvulsants, formoterol, and budesonide use. It reduces symptoms. Now, in the anti-inflammatory therapy, inhaled steroids, flutophone, advantage, it decreases sputum volume, listen, decrease rate of extubation. Now, in the management surgery, bronchiectasis is a diffuse disease, surgical extirpation of affects the area not feasible, but resection of more severe effects, segmented, bleeding, segmented area harboring resistant tuberculosis, atypical mycobacteria. Advantages, it decreases sputum production, eliminating large volume bronchial bleed, reduction in acute infective episode, improved quality of life. Procedure, that is the assisted thoracoscopy, lateral thoracotomy, complications, spread of infection, bleed, prolonged ALV, poor lung expansion following surgery. In advanced patients, lung transplantation, median survival age. So this is what we call as a lung. This is the lung respiratory illness, which is called bronchiectasis. Bronchiectasis also have comorbidities, their own clinical features and findings, and the type of treatment which we need. So thank you for the lecture today. I hope you all understand. If you have any kind of a question, then let me know.